All right, so for the next section, we're going to be talking about trauma. And really, this is pretty well covered in OEC, but there are some things that are done within the main EMS system that we can utilize that are adjunctive to what we do in OEC. So we'll review those protocols and kind of go from there. So, patient with chest trauma, put them on oxygen. We presume there's a lung injury and they're not oxygenating well. If needed, airway management, positive pressure ventilation, oral nasal airway, king airway, etc. If you have a large laceration to the chest or possibly an open chest wound, take bulky dressings and tape them onto that wound. The idea is that if you have an open chest wound and air is moving through that hole in the chest, it's moving preferentially through that hole because there's lower resistance through the hole in the chest than there is through your own trachea and vocal cords. So by packing bulky dressings on there, you control bleeding and you make that a high resistance hole, and so air will preferentially flow through the upper airway. And if need be, you may need to do positive pressure ventilation as well. If you've got someone with significant chest trauma, you also need to request ALS EMS. If you've got an amputation, first thing to do is control exsanguinating hemorrhage or extreme hemorrhage. If they're bleeding to death, they can bleed to death in under a minute from that. So you need to control that bleeding. And we start with direct pressure, and if that doesn't work, we go immediately to a proximal tourniquet, and that's a skill that we'll practice. Put them on oxygen. Airway management is needed. And note that controlling bleeding comes first. They will die sooner of uncontrolled extreme bleeding than they will of airway compromise, so you've got to stop that bleeding. You want to cover the stump with a moist, sterile dressing, and you need to request EMS. If the patient's hemodynamically unstable, they're tachycardic, or their blood pressure is at all low, they need ALS. And briefly rinse the severed part and then wrap it with sterile gauze and transport it with the patient. Don't put it on ice, don't pack it in ice, don't put it in ice water. If you really wrap it up in bulky dressings, you could put it on top of ice or snow, but don't pack it in there. You're looking to keep it cool, not to freeze the tissue. If you've got someone with a penetrating injury, again, you want to control any extreme bleeding. You do not want them to bleed to death from that. Oxygen, airway management, and stabilize the object. Now, what are people going to get penetrating injuries from on the hill? Trees and other fixed objects. So you may end up needing to cut them. And if you're going to do that, get Bill up there and his minions, and you need to stabilize the object as it's cut. You need to make sure that you have a heat sink. If it's something metal that could transmit heat, you don't want to burn the patient as we're cutting through it. And then stabilize it in place and pad it and request EMS. And if it's a significant penetrating injury, they're hemodynamically unstable, request ALS EMS. If you've got a patient with a head injury, and we're talking about significant head injury, not just a little cut and the bleeding's controlled, but someone who really got their bell rung or worse, if they have altered mental status, you're going to need to immobilize them, so spinal immobilization. Put them on oxygen, manage their airway as needed, and if they're getting any signs of herniation, and you can review those in the OEC, then ventilate them at 20 breaths a minute. Otherwise, if you're ventilating them, it's 10 to 12 breaths per minute. Treat them for shock. The most damage that happens to the injured brain secondarily happens with uncontrolled shock. So treat for shock. We're pretty limited in what we can do on the hill and as patrollers. And then EMS, and if it's a significant head injury, request ALS because they could have a seizure and need medications for that. If you've got someone in traumatic hypovolemic shock, if you can, if there's external bleeding, control it. Oxygen, airway management is needed. ALS EMS. We've talked about elevating the legs. Is really not good evidence for it. It's going to compromise their respiratory status. I wouldn't typically recommend doing it unless you absolutely feel like you're bound and determined and you've got to do it. But I would not routinely recommend it. And then we transport them head down unless contraindicated. The plus side of that is maybe you increase a little blood flow to the brain. The downside of that is the abdominal organs rest against the diaphragm. And so if they've got any respiratory distress, then you need to think about maybe you should transport them head up. And I know that's different than what OAC says, but there's really just not good evidence for this head down stuff in trauma. We still do it, but there's just not good evidence for it. If someone's hemorrhaging, you try to control the bleeding. You put on direct pressure. If you've got the clotting sponges, you put one of those on, and if it's extremity bleeding, you can put on a tourniquet. The tourniquet is, in a sense, the last resort because it's the last thing we do, but it's not really last resort. Oh my God, there's no other option. It's the third thing that you do. So direct pressure, a clotting sponge, tourniquet. Don't hesitate. Once you put the tourniquet on, you've got about 4 to 6 hours of ischemic time before the patient has permanent injury. So you're not going to hurt them by putting it on. They need to go somewhere where it can be taken off and the issue can be addressed. Oxygen, airway management is needed, EMS, and if they're hemodynamically unstable, ALS. We've already discussed the elevating the legs and the transporting head down. In this case, if the hemorrhage is from the leg, there might be some advantage to elevating it, although we don't, you notice, have elevation really listed in there either, and that's because there's not a lot of great evidence for that either, and it can make it more difficult to manage the wound, so use your judgment there. In a patient with burns, this will most likely be an industrial event and therefore an employee. Oxygen, airway management is needed. Unfortunately, if they get severe airway burns, the kind of airway management we can do probably won't help them particularly much. Call for ALS EMS. They're going to need IV fluids. They're going to need pain control. Remove the burn clothes and jewelry. If it's less than 10%, take saline-soaked sterile dressing and you can put that over the burn. If it's greater than 10%, cover it with a dry sterile dressing. And the reason why is if it's greater than 10%, there's a reasonable chance that they'll become hypothermic if you put on wet dressings from evaporation because the burned skin is no longer able to control temperature, and so they lose their ability to control their temperature well. In the patient with traumatic cardiac arrest, start CPR per the American Heart Association guidelines, spinal immobilization, airway management per protocol, request ALS EMS. Unless you know for sure this is traumatic, treat it as medical, put on the AED, focus on the adequate CPR, the good CPR, because if it turns out this is medical, that's the only thing that's going to matter, but don't endanger yourself. If this is traumatic cardiac arrest, there is essentially no survival. And so if this is absolutely a traumatic cardiac arrest patient, but you can't leave them right where they are, I mean, technically could be a crime scene. If you can't leave them right where they are, our goal is to get them off the mountain and out of public view, so to the aid room, and then have ALS EMS respond, and then have a discussion on their arrival about what to do. Chances are good that they will not transport the patient, and they'll end up helping facilitate getting law enforcement and everyone else who needs to be involved. But these are kind of tough ones. I'm more worried about a traumatic cardiac arrest, honestly, than a medical cardiac arrest in our environment because we tend to have a very young population, and so they're less likely to have heart disease and more likely to do the kind of stupid things that lead to traumatic cardiac arrest. But don't endanger yourself. It's just, this is a disease that does not have a good outcome regardless. If you've got someone with a midshaft femur fracture, make sure there's no other injuries that you need to take care of. Rule out fractures of that leg that are not in the femur, so knee, hip, tibia, fibula, ankle, any other fractures, and immobilize the leg. Now, not good evidence for pre-hospital traction splints either. That doesn't mean they don't do something, it just means there's no evidence that they work particularly in the way that we think that they work by applying traction. The good news is that they are really good at stabilizing fractures. So you can use it to stabilize the fracture. I've seen an awful lot of patients with suspected midshaft femur fractures who've had proximal femur fractures where the traction device is actually lower than where the fracture is. You can use the quick splint instead. That's totally acceptable. And if you're using the KTD, the Kendrick traction device traction thing, you need to use a quick splint on top of that. When you're removing the boot, you're going to need at least 4 people. You need to review boot removal anyway, and typically it would only take 3 people, but you really need someone to stabilize the femur. Request ALS EMS. People can bleed to death from femur fractures, and the patient will also likely need pain control. Now, making a decision where the patient's going to go, this is really going to be an EMS decision, but this can help guide you in terms of whether or not you think about helicopter response or exactly how ill this patient is. So if their respiratory rate is less than 20 or less than 10 or greater than 28, their systolic blood pressure is less than 90, or their Glasgow coma score is less than 14, they need to go to a trauma center, which for us is Eastern Maine. If there's an injury that compromises their anatomic function, so fracture through a joint, amputation, proximal amputation, they need to go to trauma center. If the mechanism of injury is really concerning, they jumped out of the lift and landed on the base of a tower, they need to go to a trauma center. Or if they're pregnant or elderly or there's medication considerations, talk to medical control. But at the end of the day, this decision is going to be made by the transporting EMS service. This just helps put you in a mindset of how sick the patient potentially is. Okay, that's it for trauma. You can go ahead and take the knowledge assessment on the trauma protocols.